Well, hello everybody. My clock tells me it is the top of the hour, so we will get underway. Thank you for joining us for this March Global Health, Nutrition, and HIV Community of Practice webinar, where we are also joined by the World Vision Christian Commitments Community of Practice for a joint discussion on the recent research that Dr. David Addis has done around spiritual themes and challenges in global health. I'm going to wait and let Dan Irvin do a proper introduction of our guest speaker, Dr. Addis, and I'll do the housekeeping bits. This is a Global Community of Practice webinar where we are open and want to have good questions, good comments. You will see that we have a chat box down below the names. And you can start the questions and discussion inside of this chat box while Dr. Addis is presenting. I will start there when it comes to questions during our discussion time. You will also note that as you entered this webinar, you were put on mute. And that is just to keep the background noise down to a low level while people pop into this WebEx over the next couple of minutes. I just ask if you will still stay on mute during the presentation, and we will have plenty of time to unmute and ask questions as you want to verbalize your question instead of typing in the chat box. But to get our fingers warmed up for getting ready to post those questions and comments, I see several names here that I am not familiar with. So let's help everybody introduce each other to everybody. Get your fingers warmed up in the chat box by typing who you are and where you're calling in from and your role, just a little something about you so we can get to know each other on this call. Thanks very much for that. All right, Dan Irvin, will you please do us the honor of introducing our guest speaker for today?
Oh, thank you, Sarah. And in fact, it is a great honor for me to welcome Dr. David Addis for our WebEx today, and also to welcome everybody else on this call. I'm really pleased to see the turnout and everybody who's gotten on. It's wonderful. Dr. David Addis is a public health physician whose work has focused on the prevention and treatment of neglected tropical diseases, which, of course, as we all know, are causes of immense suffering and disability globally. After working in migrant health as a general medical practitioner, David studied public health at the Johns Hopkins University and worked as a medical epidemiologist at the U.S. Centers for Disease Control and Prevention from 1985 to 2006. He co-founded the World Health Organization's Collaborating Center for Control and Elimination of Lymphatic Filariasis in the Americas. And from 2006 to 2010, David directed the Fetzer Institute's research program in science and spirituality. He's currently director of Children Without Worms, which is a program of the Task Force for Global Health based in Georgia. David's interests include prevention of neglected tropical diseases and the role of compassion in global health. And he is also the founder of the Center for Compassion in Global Health, which you can see online if you're interested. David is a close colleague and friend of ours. Personally, I've gotten to know David through our interactions in the Soil Transmitted Helminth Coalition, which David has directed these last couple of years and really founded and got moving forward. And of which we are a member and lead a couple of the working groups in. Last December, David published a paper which came our way, and I got a bit excited about it, which was the genesis for pulling this WebEx together. That is the paper that was the pre-read for this call. It's entitled Spiritual Themes and Challenges in Global Health, and just to paraphrase the abstract a bit, David initiated conversations and interviews with more than 300 global health leaders, students, and practitioners between 2010 and 2014. And coming from those interviews, 4 spiritual themes or challenges emerged, including compassion at a distance, dichotomous thinking, conspiracy of silence, and a compulsion to save the world. As I read through the paper, a couple of things struck me. First of all, that the theme that David is evoking here is really directly speaking to our work on an individual basis as practitioners in global health. And I would suggest, for the purposes of the audience on the call, not only public health practitioners, but probably development practitioners in general. And he begins to describe a situation in which we, in the beginning of our careers, have a level of awareness about the challenges and the problems in the world. We are affected by those challenges emotionally. It's an empathetic effect, if you will. It spurs us to action, but somewhere along the line, as we're engaging as practitioners, some risks emerge in terms of the potential to become overwhelmed by the enormity of the challenges that are out there. There's the risk of sometimes trying to do too much, getting burnt out, and the risk potentially of beginning to see the issues as statistics and numbers and just academic science versus the faces of the people whom we serve on the ground as individuals and in the full appreciation of the suffering and the challenges of those individuals at that level. And these just pose enormous challenges for us all as the practitioners whom we are. So I felt it would be a great idea to invite David to speak to us today. The subject is about really public health work and its relationship to compassion and spirituality and these challenges that I've just paraphrased from David's paper. So David, thank you very much for joining us today. It's a great honor for us, and we're all greatly looking forward to this presentation and discussion.
All right, so Dr. Addis, you have been given the presenter ball. You are unmuted. Start as you are ready.
Thank you for being with us. Can you hear me?
Hear you well.
Great. Thank you very much, Dan, and thanks to everyone who's on the webinar. I really appreciate this opportunity to be with you. My friend, the poet Mark Nepo, says that when he writes about what he most needs to learn. And that's certainly true for me and what I will share with you today. Sarah, I'm not seeing the slides. So I just need to advance?
Yeah, you should see it. I'm seeing it. What are you seeing on your screen?
Seeing just the meeting name. It says WebEx Assistance.
I'm also not seeing the presentation, Sarah.
I can see it.
Wow, that's very strange. A lot of people are seeing and some don't.
Okay.
So Sarah, I'm now seeing the welcome to Dr. David Addis slide. Can you try to advance the slides, perhaps?
I just tried to hit the... There we go. Okay. Can everyone see that?
Yeah, I think we're good, David.
Okay, very good. Well, thank you again, and thank you for that very nice introduction, Dan. It's really a pleasure to be with you today. I'll begin with a few words about my journey in global health, and what Dan didn't mention was that I was raised the son of a Baptist minister, and Dan Fountain, who was a medical missionary surgeon, was my boyhood hero. So after medical school and internship, I spent couple of years in general medical practice in migrant health, returned for a master's degree in public health at the same place where Dan had attended, and then focused on neglected tropical diseases at CDC. At CDC, my career was really very rewarding, and I was blessed with tremendous opportunities and experiences around the world, working with amazing colleagues. Although I was based primarily in Atlanta, I spent lots of time in Haiti and in Brazil, but also in Africa and Asia, working on a variety of different projects. But in 2001, the fear that gripped the United States after 9/11 also affected CDC. And this article from the New York Times in 2002 describes CDC's transformation from a premier global health agency to one that, at least for several years, was focused largely on civil defense and national security. And I found that work in global health during that period became increasingly difficult. So in 2006, I took a break, left CDC, and joined the Fetzer Institute, which is a private foundation in Kalamazoo, Michigan. And I was, as Dan mentioned, I was the head of their science and spirituality program. And this was an amazing opportunity to work with scholars and peace builders and neuroscientists, religious leaders, including on the right, Archbishop Tutu and the Dalai Lama. And one of the things that we funded and were working with neuroscientists and psychologists was the neuroscience of compassion, which explored the nature of compassion. We studied how compassion influences the brain and how compassion training can change the neural circuitry. And we also studied how emotional responses to suffering changed with this compassion training. And when I was in this environment, which was quite different from the one I was in at CDC, I began to reflect on the role of compassion in my own life. And I was impressed with how frequently hospitals and medical centers highlight compassion in their mission statements and even their advertising. So this little sign on the left is posted in the admissions office of a California hospital where my mother received care. It claims that we reach out to people in need and give comfort as Jesus did. We embrace those who are suffering. And you can see statements like this even in secular university hospitals, although without the religious language. So compassion is emphasized by clinical medicine. And within the health professions, compassion is especially prominent in the training and professional literature of nursing, certainly much more so than in medicine. But in contrast, in global health, you have to listen pretty carefully to hear the word compassion in our conversation and our discourse. It's virtually absent. So I began to wonder, what is it that motivates and sustains us in global health, including these health workers in Haiti who were attending to a patient with filariasis? When I would come back to Atlanta and visit with friends over dinner, I began to ask them, can you tell me in one word why you're doing this work? And the characteristic response when people were willing to play that game was really remarkable. Their voices would lower, their face would soften, they would say, often very softly, words like caring or compassion or love. But we had never talked like that at CDC, and I began to wonder what was up with this. So in 2010, I helped to convene a meeting of global health leaders at the Carter Center to explore the role of compassion in global health. And they concluded after 2 days of deliberations is that global health is rooted in the value of compassion. It's grounded in an awareness of our interconnectedness and a concern with the whole. So for many of these global health leaders, it was the first time they'd actually spoken publicly about the central role of compassion in their own life and work. I'd like to, at this point, pause to define what I mean by global health and look at it from a variety of perspectives. Jeff Copeland and his colleagues have argued that global health can be seen through 3 different lenses. The first lens is an idea, a notion, global health is an idea that's rooted in the awareness that we're all interconnected. And global health often requires global cooperation, from the halls of WHO to rural African villages. My favorite example of this interconnectedness is the story of the drug ivermectin. The man in this photo on the lower right is blinded by onchocerciasis, or river blindness, and he's being led by his grandson, who's already infected with the onchocerca parasite. The ivermectin that will prevent his grandson from going blind was developed from a molecule that was originally isolated from a fungus that was found on a golf course in Japan. It was tested as an anti-parasitic drug for cattle in Australia, developed for human use by the pharmaceutical company Merck in New Jersey, and this effort was led by a Bangladeshi physician, Muhammad Aziz. Eventually, Merck donated the drug free of charge to control and now eliminate onchocerciasis in Africa and Latin America. And so this is a great example of a global solution to a local public health problem. The second lens with which we can view global health is that it's an objective, the objective of health of all people. And this objective is in service to health equity and social justice. And the third lens that we can use is academic and professional discipline, involving both clinical care and prevention, and attending to the needs of both populations and individuals. Now, at its fundamental level, though, I think that the words attributed to the late performance artist Steve Ben Israel to describe his life's work are a good description of global health. He said he was trying to foment a mass uprising of compassion. And I think global health is a mass uprising of compassion because it's dedicated to relieving suffering on a massive scale. But viewed from this perspective, that is a mass uprising of compassion, I wonder whether we might approach our work in global health as spiritual practice. For the purposes of discussion, I'd like to consider a broad consensus definition of spirituality, which was developed for use in palliative care, of that aspect of humanity that refers to the way individuals seek and express meaning and purpose and experience their connectedness to the moment, to self, to others, to nature, and to the significant or sacred. Now, why do I make this connection between global health and spiritual practice? Well, first, so many of us in the field enter it, as Dan said, out of a sense of calling. And those with religious faith often speak of it in terms of a religious vocation. And I believe the work can indeed provide meaning and purpose and a deep sense of connection across barriers of culture and language and politics. But I can also say from my own experience that when that inner sense of vocation is lost, so is the sense of meaning and purpose in the work. The second reason I think that global health can be seen as spiritual practice is that many of the core values of global health are shared with the world's religious and spiritual traditions. And primarily among these is compassion. Karen Armstrong, the scholar, says that compassion lies at the heart of all religious, ethical, and spiritual traditions, and this compassion impels us to work tirelessly to alleviate the suffering of our fellow creatures. The other shared values between global health and religious traditions include respect for human dignity, justice, generosity of spirit, fearlessness, humility, gratitude, connectedness with all humanity, wonder and awe. And indeed, these last four values are hallmarks of spiritual experience. So I think there's a lot of common ground in our values between global health and our religious faith. As Dan mentioned, I've been exploring these ideas with colleagues over the last several years, and I've been very interested in the challenges that we face in staying connected to this spiritual impulse that animates our global health work. And as Dan mentioned, there's four themes that emerged from these conversations. I call them compassion at a distance, dichotomous thinking, conspiracy of silence, and compulsion to save the world. And I'd like to look at these one by one in our remaining time. Many models of compassion boil it down to three different elements or components. And they say that for compassion to emerge, you first need to be aware of the suffering. There has to be cognitive attunement. The second is an emotional attunement or empathy in response to that suffering that is perceived. And then the third is action. It's not compassion without action, or at least a desire to act, to relieve, and in cases of global health, prevent suffering. These three components are shown in more detail in this composite model, which comes from social psychology. In the left-hand column, for compassion to emerge, we need to be aware. We need to recognize suffering as suffering. And in global health, we can't often see the faces of suffering. As Dan mentioned, we rely instead on data. So we have to be attuned to the data and be able to see the suffering that it represents. This cognitive awareness can lead to empathy or emotional arousal, which is shown in the middle part of the slide. And one of the challenges we have in global health is that the empathic signal may not be strong enough. When I sit here in Atlanta behind my computer screen looking at numbers, I don't see the faces of suffering. On the other hand, I may be asked to work for short periods of time in situations of tremendous suffering, disaster, or refugee settings, in which I'm so emotionally aroused that I experience personal distress in the lower part of the slide. And if that happens, I respond by getting angry at the situation, fighting, avoidance, which would be more likely in my case, flight, or going numb, freezing, shown in the lower right-hand part of the slide. But if I do take action with that mentality or that spirit, it's more about me alleviating my own distress. And psychologists have called this selfish pro-social behavior. But if I can stay with the suffering, if I can regulate emotionally and accompany the person who is suffering, then compassion can emerge and I can take action to alleviate it, or again, in public health, even prevent it. And a critical point in this model in the upper right-hand corner is that the action should not be too attached to outcome, which seems paradoxical to us in public health or medicine, since how do we justify and fund our programs if we don't ensure measurable outcomes? So we're often very much invested in the outcome. And we'll return to this theme in a few minutes. Now, there's many challenges to compassion in global health. I'll just mention a few of them here. First, it's hard to have compassion for entire populations from whom we're separated by great distances, cultural differences. How do we have compassion for the multitudes as Jesus did? In a speech to CDC several years ago, Bill Foege, who had been the CDC director, said that if we are to maintain the reputation of this institution, CDC, it will be because in everything we do, behind everything we say, and as the basis for every program decision we make, we will be willing to see faces. This was remarkable. He was saying that what CDC didn't need better programs or laboratories or epidemiology, but the essential thing that it needed was to see the faces of suffering individuals. A related challenge to compassion is that we often work in large bureaucracies through complex partnerships, and organizations have their own agendas. The instruments of our compassion are often programs, budgets, and supplies, and again, so we're removed from the faces of suffering. And then there's competing values. Much of our funding from global health is determined by economic or political considerations or national security concerns, which may or may not align with our vision of global health. And then finally, fear is a major challenge to compassionate action in global health. Before the first Ebola patient was airlifted to the United States, CDC Director Tom Frieden said that I hope our understandable fear of the unfamiliar does not trump our compassion when ill Americans return to the U.S. for care. And of course, we saw both tremendous fear and compassion during the Ebola outbreak. Now, the second theme or challenge in global health is what I call dichotomous thinking, either-or thinking. This kind of thinking is built into our epidemiology as the scientific basis for global health, and it's been a very powerful tool. We think in terms of sick, well, alive or dead, ones or zeros. But either-or thinking does have its limits. Richard Horton, the editor of The Lancet, said, "We do this really badly in global health. We have false dichotomies, prevention versus cure, horizontal versus vertical." And Julio Frank, the dean of the Harvard School of Public Health, said that the greatest threat to global health is dichotomous thinking. Pretty powerful statement. Again, going to Bill Foege, he reminds us that global health is non-dual in many ways when he talks about global health being everything. It's local, everything's global. Global health is not over there, it's right here. It's where we are right now. He also points to a non-dual or non-dichotomous capacity that's required for global health leadership, the ability to see the whole and its parts simultaneously, to scan and to focus and to see relationships, and to do this all at the same time. This kind of non-dual awareness, seeing faces and numbers at the same time, is not taught in schools of public health. Now, one of the most persistent dichotomies is the separation that we maintain between our inner lives, our spiritual, and our religious sustenance, and our work in the outer world. This calligraphy on this slide, painted by the Vietnamese Buddhist monk Thich Nhat Hanh, illustrates this point. The circle, or the enzo, is a symbol of wholeness. Wholeness requires both a sense of peace in oneself and peace in the world. Neither one alone is adequate, and neither is really possible without the other. When I first saw this image several years ago, it stopped me in my tracks. I had dedicated myself for years to achieving the bottom half of the circle, peace or health in the world, but I was neglecting my inner life, and I was far from peaceful or whole. Now, a third challenge is what I call the conspiracy of silence. Why don't we speak about compassion or our values in public health? Why don't we speak about them in public? But when space is opened up for this, such as at this symposium on compassion and global health at the American Society of Tropical Medicine and Hygiene several years ago, there was standing room only, and people in the audience, eminent scientists, were eager to share their own stories. I believe that our silence about our core values isolates us as individuals. It also makes it harder for us to withstand the forces that challenge these values, and it limits global health as a field from realizing its full potential. Now, the fourth challenge is what I call the compulsion to save the world. And you could see this as the shadow side of our desire to make a difference in the world, which is valid and noble, and we need this desire. But the drive to rescue the world is tricky because the ego over-identifies with achieving the outcomes that we planned on. We tend to engage in compulsive overwork, and ultimately this leads to burnout. He wasn't speaking about global health, but the Cistercian monk Thomas Merton reminds us of the high cost of this compulsion to save the world. He writes, to allow oneself to be carried away by a multitude of conflicting concerns, to surrender to too many demands, to commit to too many projects, to want to help everyone and everything. I wonder if this sounds familiar to anyone. Is itself to succumb to the violence of our times. These are very strong words. After a conversation with a prominent AIDS activist in a noisy Manhattan restaurant one evening, I received this email which eloquently describes how we get caught up in our work and we don't see the faces of suffering around us. He said, I don't think I'd verbalized to anyone before the disconnect I sometimes feel between the compassionate nature of my work, all nonprofits doing extraordinary public health and social justice, and my avoidance of dealing directly and compassionately with friends and family who are in psychological or physical distress. But wait a minute, say, Addis, you've already said that compassion requires action, and now you're saying, wait a minute, you're talking against action. Well, the Dalai Lama has something to say about this, and he speaks commonly about compassion, and he highlights the importance of action. He says compassion is not just a wish to see sentient beings free from suffering, but an immediate need to intervene and actively engage to try to help. A person who's attained stability in his or her compassion training should now be out running around like a mad dog, actively engaged in acts of compassion. Well, our action in global health is mad dog impressive, but notice that the Dalai Lama is speaking of compassionate action that arises from a sense of inner stability and spiritual groundedness. And this, I think, is often missing in global health. We're so busy addressing the tremendous need around us that we would do well to be reminded of the words of Seraphim of Sarov, the 18th century Russian Orthodox saint. His prescription for saving the world is acquire a peaceful spirit, and around you, thousands will be saved. In my interviews and conversations, I've asked many of our colleagues and some of you online today about our practices that nourish us spiritually. And at the individual level, I think it's very often traveled to the field to literally see the faces. This photo was taken in eastern Nigeria. I'm shaking hands with a woman who was blind. She was astonished by how soft my hand was, and she was saying to my colleagues that I must not do much work. Visits to the field like this with colleagues and to see the work is just very rewarding and really grounds many of us. We also find nourishment and remembrance in hanging photos on the wall from those travels to help us remember. Warm personal relationships with our colleagues from other countries, personal daily rituals, which many of us have but don't speak about very much. Compassion training can be very useful. And there's a group at the Claremont School of Theology, Frank Rogers and colleagues, who have designed very powerful compassion training from a Christian perspective, which I would recommend. And then there's spiritual practices such as prayer. Martin Luther is quoted as having said, I have so much to do that if I didn't spend at least 3 hours a day in prayer, I would never get it all done. At the collective level, sharing our personal stories can be a very powerful reminder of why we do this work. I think we can also do more collectively to celebrate our joys and successes, as well as expressing our sorrow and offering apology for the unintended consequences of our actions. Religious fellowship can be very important, especially for faith-based groups, and also periodic individual or collective retreats to recharge our batteries. At the organizational level, I think global health as spiritual practice can be realized as spiritual practice through more access to chaplains. I think we in public health sector neglect our own spiritual health. If you're a soldier in the military, you have access to chaplains, but if you're a uniformed officer in the U.S. Public Health Service, as I was for 20 years, you don't. There's no chaplains in the Public Health Service. Second, there's, I think, deep reflection and dialogue can help make global health a spiritual practice. In the 1970s, the Christian Medical Commission of the World Council of Churches sponsored a couple of conferences in Tübingen, Germany, on the healing church, in which you had medical people, theologians, reflecting deeply on the role of the church in the late 1960s and mission hospitals moving into the 1970s. And this led directly to the primary healthcare movement. I believe that a similar process could animate and inspire global health today. And then finally, I think we can do much more. We can be much more explicit about our organizational values and our commitments. I'd like to close by offering a few reflections on Jesus' parable of the Good Samaritan and ask how might this parable relate to our practice of global health today. Well, first, the Samaritan understood at a very deep level that his life was interconnected with the life of the man by the side of the road. He responded out of love, and I think we can presume that he responded out of a sense of obedience to his vocation. He was predisposed to this kind of service. Let us hold on to that sense of connection and vocation that we have. Second, the Samaritan saw the man. He bore witness. He didn't turn away, and he also allowed himself to feel as well as see. He opened himself to empathy. May we too bear witness to suffering and not turn away. Thirdly, the Samaritan acted. He went to the man and he did what he could to take care of him. He dressed his wounds with oil and wine, presumably with some degree of skill, and then he left payment for the innkeeper. You all have specific skills and gifts. The important thing is to offer them. Fourth, and I think this is important, he finished his own journey. He didn't give everything away. He did not injure, hurt, or neglect himself. In Merton's words, he did not succumb to the violence of our times. Theologian Jean Stevenson Mosner reminds us that in genuine caretaking, the caretaker is not submerged. With genuine, mature compassion, there's no compassion fatigue. As you engage in your important work, I urge you to have compassion, especially for yourself. And finally, the Samaritan brought the man to an inn, to a place of refuge and shelter and of healing and restoration. He relied on others. In global health, we need each other. This work is relational, intensely relational. It's a community effort. The Samaritan did not need to be recognized or praised, and in a sense, he let go of the outcome. We don't know if the injured man was still at the inn when the Samaritan returned to square up with the innkeeper. I imagine that he had already left. I'd like to thank you so much for the opportunity to be with you today and to share these thoughts, and I'd like to invite you to the website that my wife Julie and I have developed to help bring compassion into our global health discourse. I very much look forward to your questions and comments. And again, thanks so much for listening and for the opportunity to be with you today. Thank you.
Sarah, I think you're coming on, but I don't hear you. Now you're muted now, Sarah. Okay. I'm going to share a couple of reflections on David's presentation, and then I'll hand it over to Dan Olshani. And Dan, I'm greatly looking forward to your thoughts, so I'm not going to take too long, but I do want to make a couple of quick comments. First, David, thank you so much. I know that this presentation is resonating deeply with the audience on this call. I'm also looking forward to the participants' comments and questions. So to move towards that, let me say, I see in your presentation two levels of consideration of compassion. There of course, is the issue of our compassion as practitioners towards the people whom we serve and all the catalyzing factors involved in that. And then there is the question of being compassionate towards ourselves as practitioners and taking care of ourselves. And as you had pointed out with the Dalai Lama's example and the Martin Luther example, being well-grounded spiritually so that we have a strong spiritual foundation and compassionate foundation and well-being to provide us the energy that we need to optimally serve the people whom we're working with. I want to comment that you mentioned early on about your interviews and your engagements with medical practitioners through your career as saying kind of very gently and in a whisper that, you know, they really got into the medical sciences and public health because they care about people. And it's so important. In my experience, for example, meeting with community health workers around the world, one of the first questions that I almost always ask them is, why are they doing what they do? And they're often doing it as volunteers at the community level. And without fail, the first response is always that they're doing it because they care about their community and they want to help improve people's health. And I've come to believe that it's very genuine what they're saying. In the group of participants on this call today, there are many medical professionals, many of them doctors. It's always been very interesting to me that so many people in the World Vision staff at all levels have set out in their careers as medical doctors, but somewhere along the line, the medical practice wasn't even enough for them, and they wanted to branch out into public health and reach greater populations and extend their compassion out that way. And I've always thought that was a very fascinating phenomenon. There are some elements of your presentation that I'm sure have stuck and will stick with the participants on the call, like the term mad dogs. I'm sure that people were chuckling to themselves when they saw that. I'm sure it resonates with us all, and we ask ourselves the question, are we mad dogs? I'd like to share with you that a couple of things. One, we have a survey that our HR department conducts each year across the organization. It's called the Our Voice Survey. And the survey is focused on exploring the well-being of our staff within a number of dimensions. And we do a lot of critical analysis of the results of this annual survey. What we are seeing over the last couple of years amongst health staff at all levels of the organization is that the survey results are coming in below average for the organization and well below average for the industry. And it really has caused us concern in terms of the sources of non-well-being for our staff. Some of it is organizational, but I think that some of it may also be the immense pressures of doing the work that they do, burnout in some cases, a feeling of working tirelessly, to use the language of your presentation, and maybe not being adequately appreciated for that work. And maybe it's related to trying to do so much all the time and becoming a bit desperate in that process, because it is a very difficult engagement. But at the same time, I also believe that in World Vision, we have a great advantage of being a faith-based organization and working in an organizational space where we dedicate time to our spirituality. We take time out for the practice of our faith and for prayer and for discernment. And I think that if it wasn't for that, we would actually be in a much more difficult situation than we are. I think that our spiritual practice has been a great advantage for us as an organization, and we're lucky to have it. it's related to the one slide you had speaking to the need to have peace in ourselves to engender peace in the world. That's something that certainly we need to continue to invest in deeply. So I think those would be the last comment I would make just very quickly, and Christo Grayling, who is also a pastor but leads a large part of our faith and development work, commented in the chat box that the awareness, emotion, action framework is similar to the process that we engage in our Channels of Hope programming with faith leaders and development in communities where we work. I was going to make a similar comment that it's quite similar to the behavior change theory that we're often evoking with the people, the populations where we're working. But I would ask the participants on the call, do we apply that same framework of thought and theory to ourselves as practitioners adequately? And Michelle Goudreau put a comment in the chat box somewhat to that effect, also exploring that question of how do we apply that framework to ourselves as practitioners. So let me stop there and invite Dan Olashani to make a few comments, and then we'll go to the participants. Dan?
Thank you very much, Dr. Addis. I really enjoyed your presentation and learned a lot, and appreciate the deep passion you have for the people you work with. It's very evident, and I'm sure your hands and mind and heart of compassion have transformed the lives of many. I'll start with your last point, which was a wonderful exegesis of the Good Samaritan story from the Bible. And I said to myself that exegetic ability must come from your Baptist roots. So I can appreciate that, because I am going to a Baptist church presently myself, and have gone for many years. But I really do want to just start with an appreciation. The second thing I wanted to say is that I was struck by your point, sort of towards the beginning of your presentation, when you said that you noticed compassion was largely absent in health, and you know, it was sort of an aha moment for you. And what I appreciated about that is related to a remark or an observation made by a man called Vishal Mangalwadi, an Indian, who wrote a book called The Book That Made Your World. And in that book, you know, he points out something very interesting. He says that compassion was one of the driving forces behind the Christian contribution to medicine. And he actually points to that as really probably the single most transforming thing to medicine, because he points out that, you know, the Chinese, the Indians, and of course Islamic civilizations all practice medicine. But it was this element of compassion that really transformed it. And he points out that, you know, monasteries were the real pioneers of, you know, the Western culture of care. So I'm intrigued that as you reach that aha moment, from what you said, at least, you pointed out that you were struck primarily by your question in Haiti, asking health workers why do they do that work? Often very difficult work, very demanding. Why do they do it? And their response. So indeed, something good can come out of Haiti. Thank you for that affirmation. That good things can come out of difficult places. The other thing that I appreciated was your notion of global health as a spiritual practice, a sense of calling, you know, shared values, and so on. And I'd never thought of health in that way. Now, I'm not a medical person, and I'm not a theologian either. I'm just, you know, throwing out all these disqualifiers. But But I did appreciate that point immensely. And then I think as you went on to develop it further, I was struck by two things under challenges, compassion and global health challenges. Number one, population, not individuals. Our vision statement says our vision for every child. And so I think we, World Vision at least, try to intensely sort of focus on the individual. And you know, we talk about child well-being. That's what we aspire to. That's what our targets are created around in different areas. And so I'm just affirming that point. The second thing is that the other challenge is bureaucracy. And I've been with World Vision many years, for those of you who know me on this call, soon to be 34 years at the end of this month. And, you know, I've spent considerable time on the program side. And I do remember that when I initially started to move away from that and spend more time in sort of, you know, head office, doing more managerial stuff, it was a real challenge for me because I in fact, I didn't like it. I said, you know, this is not what I signed up for. You know, what am I doing behind a desk? You know, managing people who are, you know, pushing papers. It was papers in those days. And I can't really see the impact of what World Vision stands for. And so whenever I would go back into the village or into the community that, you know, World Vision was working with, what a sense of renewal that I would experience. And I think colleagues on this call probably feel the same way. Although I don't know many of you, you're health professionals, you probably spend a lot of time on the front lines. But just your caution that, you know, bureaucracies can create this sense of alienation. You know, large, complex organizations like ours, you know, in some ways can actually take away this idea of health as a spiritual practice, one that gives you renewal. And then I'll end with these final thoughts. Compassion is powerful. Now we know that from the Bible, you know, the example Jesus set when he washed his disciples' feet, you know, the word he focused on there was service motivated by love. And so while we use compassion, I think in World Vision we tend to emphasize more that idea of service that is motivated by the love of God. I think there's a close tie between the two. I mean, in the story you shared of the Good Samaritan, the Bible doesn't refer to them as good, but we can tell from their actions that they are. I'm sure that love was part of the motivation. And then the idea of human dignity I appreciate that, understand it. Again, we tend to use more and more the biblical idea of human beings made in God's image. Now that doesn't work everywhere, and I know Dave Robertson is on the call, and I think Muslims tend to appreciate the word human dignity. The word made in God's image is just not, it's unsettling to them. But anyway, I think there's a relationship between the two ideas. But if you have time on this call, and I recognize that others want to speak, it'd be interesting to get your thoughts on that. Fearlessness, we increasingly use the word, holy boldness or boldness in speaking up, for injustice, and I think the two relate very well. The idea of humility, again, we related to the idea that God became a man and showed us an example of the most profound humility that could ever exist. And then finally, the notion of connectedness. I think it's wonderful that as mostly Christians in World Vision, we see ourselves as being part of this spiritual family called Christian. But we also see ourselves as part of the global family called humanity. And we always have a foot in both worlds. Sometimes some people are skilled at doing it, others are not. I think the ideal is that we always have a foot in both worlds because we are members of both those families. So thank you again, Dr. Addis. Really appreciate this.
We will see if my audio is coming through. I think it is. Thank you, Dan, and Dan, for your reflection. Dr. Addis, I'm going to give you an opportunity to respond to some of the reflections, but while I do that, before I do that, I'm going to just open this. I see several questions, comments in the chat box. If you've been thinking about something you wanted to say and would rather speak it, you can, of course, use the raise hand feature, the little photo of the hand that you'll find below the participant list. I'll look for those raised hands as well if you would like to be called on. So before I jump into a few questions in the chat box, Dr. Addis, do you have any responses to our Dan and Dan reflections?
Let's see, try to.
We hear you now.
Sarah, can you hear me?
I do.
Okay, good, good. It's like I still had, I was muted, but great. Well, thank you both Dan and Dan. Those were really wonderful comments, and there are a lot of things that could follow up on. And your final comments about the different ways of expressing some of these values, for example, service motivated by love. I think that's a beautiful definition of compassion. And I think these other, human dignity, being made in God's image, I think these are very powerful ways of expressing, in many ways, very similar concepts or the same things in ways that actually, for me personally, carry a greater depth and a greater meaning than some of the words that I used. I think one of the challenges, and this relates to some of the comments that I've seen on the screen, is how do we speak about this both among ourselves but also among our colleagues in global health, which is largely a secular endeavor. And I think that the words one uses in many ways have to be tailored to what the audiences are open to hear. In some situations, I think even the word compassion can make people feel unsettled because it's too emotional. But in other settings, I think it's where we can go deeper and use the words that mean the most to us. I think it can be much more powerful. So one of the challenges that I've faced is how does one speak these different languages in ways that open hearts and open ears and open our voices so that we can share our stories and explore this together. So I really appreciate your comments. And Dan Irvine, also, I just thank you for sharing your reflections about the community health workers. I think clearly the caring and compassion with which they do their work is just phenomenal. And if we look at compassion or service motivated by love as a primary motivating force, it's just hugely important. Without it, we wouldn't have global health. We wouldn't have so much of what we take for granted in our lives now. So part of what my effort has been is to reveal this, to try to understand its dynamics and to celebrate it and allow us to share it more fully with each other. I think I'm interested in what others might have to say, Sarah, so that's all I'll say for right now.
Sure. The first question I'll bring up is actually one of the last, but it's from one came in while the Dans were speaking. This question is from Dave Robinson. For your point on silence about compassion, the World Bank is creating an updated set of safeguards for its project designs to ensure all benefit from its funding. Until recently, religion was ignored. They are struggling to figure out how faith, spirituality, and religion fit into their understanding of social impact. Any lessons from your CDC days?
Wow. I wish I had some better lessons to share. I think in many ways our global health organizations, whether it be WHO or UNAIDS or the World Bank, have been caught flat-footed with the religious forces that shape our world, and in many ways religion and spirituality have been quarantined in our global health discourse. There is now a group at CDC that is a bridge between CDC and faith-based organizations. I think we see that more commonly in other organizations as well. But I think this is something that needs a lot more attention and a lot more dialogue. So I wish I had something more positive and more robust to share from my CDC days. I think my journey actually was stimulated largely in part by a lack of those resources and a lack of that connection when I was at CDC.
Thank you. There are a couple of questions, comments here as we're talking about compassion and levels of compassion. And of course, because we're talking with an audience with a lot of global health professionals, there is a question here about, in the field of global health, how do we measure or quantify level of compassion in global health?
It's a great question, and there are measures of organizational compassion that have been developed. There's compassion measures for individuals, and some of these have been tested and, in a sense, validated with neuroscience and sort of the tools of social psychology. Those in the organizational realm are much less developed and I think harder to measure, and when you start developing tools that measure things like compassion, you open a lot of conversation about what is compassion, how is it manifested, and just even looking at compassion is how one views it. It is very different depending upon your perspective. So there are some measures of organizational compassion. I don't know if they're robust enough to be useful for those of us who are thinking about the field of global health or to provide guidance for organizations that want to improve their compassionate nature and their compassionate expression. In many cases, historically, we see compassionate organizations emerging with a very dynamic, compassionate leader who leads by example, really a servant leader who is able to bring the whole organization into alignment. That's a hard thing to prescribe as a sort of a technique. So I think we have a lot to learn about that. I personally have a lot to learn and explore with folks who have studied organizations and may have more insight on this than I do.
Thank you for that. Lots of good questions coming here. One of the questions, a reflection question really, that came early in the presentation that Dan alluded to was from Michelle Gaudreau. She says, the question I grapple with sometimes, is it possible to have the cognitive awareness but not much emotional arousal and yet make a conscious, intentional decision to act, emotional or non-emotional, and consider that to be compassion? Because you're acting in an intentional service way, whether you feel it or not.
Yeah, that's such a great question, and I believe it is. We don't have to be overcome by emotion in order to act, and I think this relates to our predisposition and our willingness to be open. So it may be that when we see suffering, we don't necessarily register a big emotional response, but we move instinctively into action to relieve that suffering. And I would say that it definitely is compassion, even if we don't recognize a large emotional component to it. In fact, this aspect of emotional regulation is it's something that it can be with too much emotional stimulus. We're frozen. We don't act. We're actually, it becomes about our own emotional upheaval and distress. And so one could say that the optimum amount of empathy is the amount that allows us to move from perceiving suffering to compassionate action, rather than stirring up a lot of emotion within us. Yeah, I guess I would, so I would basically affirm the question that one certainly can be compassionate and act compassionately, even if one does not recognize a large emotional response within oneself when viewing suffering.
I know we are past the top of the hour, but we do have 2 other questions. If you can stick with us for a few more minutes, Dr. Addis. Is that okay? Or...
Yes.
Perfect. And the first one, I had someone raise a hand. So, Mercadon 1, I'm going to unmute you since I see you wanted to ask the question. So you are unmuted. Go ahead with your question.
Hello?
Hello.
Hi, Sarah. I'm sorry. Earlier you were trying to get me to introduce myself, and I couldn't even unmute. I was just like trying to press all these buttons. But I'm Naija Macardo. I'm actually a recent graduate in a public health field, and I'm not actually like a professional right now, but I really want to say thank you to David, Sarah, and Dan for just facilitating and even, presenting and also coordinating this whole webinar, because although I'm not an actual practitioner, I still took a lot away from this workshop. And one of the things that, that caught my attention mostly was David had said, we catch on to like work and numbers, but we lose focus on like the faces that are suffering. And as he said that, like I couldn't help but to think of our emotional intelligence, like our wisdom, and it's very connected to compassion, because it's like our emotional intelligence is like that self-awareness and self-management and just knowing thyself, and also like having that social awareness and relationship management to even like give and care and have that empathy, So as I was thinking of this, and as I'm hearing him speak about compassion, I was like, wow, we have to reflect so often on like, why do we do the work that we do, and is the appreciation there, and you never want to get burnt out and lose that sight of, compassion. And I think Ann Old Shiny also said, sit behind a desk. And, you want that sense of renewal so that you can remind yourself, like, why am I doing the work that I do? I have this passion for public health, and as I'm trying to find myself, I'm only 22. So as I'm trying to find myself and find where I'm trying to go, I knew that I always had this connection with epidemiology, but I find myself now so connected to like higher education and trying to get, students to find themselves. And it's interesting because as I'm trying to find myself, I'm also trying to work in like this higher education kind of counseling area of like trying to get people to, find that compassion and what they do. And I think that's important as we think of public health and world health. Is in every area, compassion is sometimes absent. And I just really appreciate, just this lesson on compassion and basically why we do the things that we do, and to stay on track and, don't lose that sight of, of like how Jesus' life, like he didn't lose his sense of compassion. Like he loved and cared for all of us. And it's just amazing to see that, I came into this, I was like looking on Google, and I found this webinar, and I was like, interesting, I want to get connected, and here I am. And I just want to say thank you, David, and thank you, Sarah, for, facilitating all this. I really do appreciate it.
Well, thank you. We have a new public health professional on the outset. We have one other, the question will end on here. It's from Seamus. And it's part of a reflection on where we're talking about compassion, but what else? So is there any thinking out there on how spirituality affects people's ability to address health problems? Compassion is one positive result of spirituality. What are other positive and negative aspects of spirituality that impact health results?
Wow, that's a big question. That's a big question, and there are so many positive, depending upon the health of the spirituality. I mean, spirituality can be very healthy, but it can also be distorted in some ways, and you could argue whether it's still been true spirituality or not. But certainly, it can be, it can have very positive impacts, and I think there would not be a global health without the spiritual and indeed religious impulse in many people that have contributed to the field and created it. There's a book that Ellen Idler, who's at Emory University, has created on religion and public health. She edited a large volume with many different contributions, and it just came out last year. And it's a phenomenal book that explores many of these issues, the role of religion in public health, particularly global health, from a variety of perspectives. And I would refer people to that book. Her last name is Idler.
Thank you. I will find that reference for our notes and resources for this call. I know this group could probably continue and hold your time, Dr. Addis, on this topic, but I know we are already way over our time. Just want to say thank you again for facilitating this discussion. And this was a bit of a different discussion for our Global Health COP. We took a break from our log frames and program reviews to do a bit of personal introspection, and so thank you for allowing us and leading us through this conversation. It was just very nice. All right, so I'm going
let me just say quickly also thank you, David, and I put the link in for the website for the Center for Compassion in Global Health that David has founded. It would be great for people who are interested to have a look at the site. It's very interesting, and there are opportunities, explicit opportunities built into the site to engage. And based on previous discussions with David, I know that he would welcome your engagement and your thoughts and contributions there. So please do go in and have a look and engage.
Thank you. And just a few announcements here as we close. FailFest contributions are in, but your job is not done. Please go in and vote for your favorite lessons learned from failures. Results are being compiled, and winners will be announced later this month. And I'll skip to this last slide. We are a very active community of practice, and we have a lot of good learning and sharing happening through our interest groups and partner communities of practice. So up here on the screen are some upcoming dates for different learning opportunities within the COP. And again, just a huge thank you to Dr. Addis, and a big thank you to all of you who were our live participants on this call. Notes and recordings will be sent out shortly. Thank you, everybody. Have a great day, and see you on the next WebEx.
Thank you so much.
Thank you. Have a good morning in Georgia.
Okay, I sure will. Thank you, Sarah.
Hey.
Appreciate it.
Thank you.
Thank you.
Thank you.
Welcome. Come again.
Bye.
Bye.
Thank you.
Bye. Thank you.
Bye.